So I want to start off with a question, and you can drop your answers in the chat. When you have a new room of children, it's a new school year, you're getting used to a new group of kiddos, how do you get to know the children in your class or in your program if you're a director? What are some of the things that you do in order to get to know the children in your classroom? Think about it. What's some of your favorite activities? How do you go around and get to know 20 kids if you have that many? Or if you're in an infant room, how do you get to know the ins and outs of, 10 little people at one time? What are some of your secrets? All right, watching them play with peers, small group activities, and all about me week. Asking parents, that's a great resource. Parents are the expert on their kiddos, so getting information from them is always a great way to start. Home visits. I love home visits. That's a hard one to do anymore, but getting to see the family in their natural environment always gives you a lot of information. Um, all about me worksheets, just watching kids do curriculum, spending time with your kiddos, specifically sitting down on the floor doing activities with them during free play is a great way to get to know everybody. Um, let's see, asking parents to fill out information, lots and lots of questions. All right. So, one of the things that I want to start off talking about tonight is if we are thinking about assessment and referrals, it's essential that we know our kiddos. And at the beginning of the year, when we're learning about kids and we're taking time to get to know them, um, some of we start to notice, are they ahead in some areas? Are they meeting their milestones, or are there things that they're really struggling with? And so as we get to know children better, we have a much better chance of being able to accurately assess them and then figure out if they do need a referral for any type of developmental delay down the line. So just think about how you plan those activities, getting to know individual kids, and especially quiet kids, especially kids that are more reserved, really finding a way to work with them one-on-one and kind of get that information out of them as they start to feel more comfortable around you. To start off tonight, we're going to talk about developmental monitoring. So this is a little bit different than using an assessment or a tool. This is just how we learn about those kiddos. This begins at birth. As soon as a child is born, you can start to monitor what they're doing, what they don't. When is the first time that they can roll over, hold a rattle? It's an ongoing process that we're always watching. It does not require any type of training. We are just watching and making notes of what kiddos are doing really well and what their strengths are. I think so often when we have parent-teacher conferences about a child that we're worried about, we start to tell parents all the things that they aren't doing, but it's essential to think about what their strengths are and the things that they are doing really well. So developmental monitoring really includes just learning the full spectrum of everything that a child can do. Now, we do that so many different ways. General observation, sitting down in the classroom and watching kids, especially during free play. Anecdotal notes. To me, anecdotal notes is just having my notebook and just writing down what I see kids doing. They're building with blocks. They stop to talk to a friend. They walk back over by themselves. Maybe they only like to play by themselves. Maybe they're always in a group. Maybe they like the big, exciting, gross motor activities, dramatic play, things that are very social, but they kind of avoid the quiet and more fine motor oriented activities, just getting an idea of what's going on. And it's like almost fluid thought. You're writing down everything that you see in the classroom. Another way of monitoring is work sample portfolios. This is a great way to track things like fine motor. Are they cutting? Are they gluing? Can they hold a crayon or a pencil? And if we watch artwork and pictures they create over the course of the year, you can really get an idea of how they're developing. It goes from scribbles to eventually something that looks like a person with a really big head and, eventually goes into a story. And that work sample portfolio is great to show parents because a lot of times parents might not know our lingo for early childhood when we say, well, in this developmental domain, this is happening. But when they look at those pictures they've created and see how that changes over time, they really get an idea of how their child has grown. Developmental checklists just help us as educators keep in mind, yes, we're doing this, 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 but we haven't quite achieved this. So that's probably the next thing we need to work on. Parent interviews, several of you said you start off by asking questions to the parents, and that's just a great place to start. We see the kids all the time in a group setting. Parents see them in a more one-on-one setting, and so sometimes they'll show parents the very best of their skills as well as the very worst of their behaviors. They usually save those for parents, the best and the worst, and the teachers get the middle. But parents can tell us about strategies that work at home that have been working for a long time. They can tell us things that a child loves to play with at home that we might not have in the classroom, and we can adapt the classroom for that. Um, there's just so much good information that they can offer. So that parent interview piece is just fantastic when we're monitoring behavior. And then the last thing on here is play-based assessment. So that means that while a child is doing an activity, maybe we're doing baby doll washing in the classroom and the child has a bucket of soapy water and they've got a baby doll they're going to give a bath to and then dry off. We see, can they follow multiple step activities? Do they have the fine motor skills to, use the wash rag and scrub? Are they adverse to putting their hands in the water, the soapy water? Do they have sensory experiences? And so those play-based assessments give us multiple domains at one time. And they're much more natural for kids than if we do things like, can you stack 5 blocks in a tower? That sometimes a assessment tool might say, can they cut on a straight line? Can they stack blocks? Can they do very technical things? But in a play-based assessment, we really can see multiple things at once and assess a lot of different skills. So, in the scope of monitoring, one of the things that we can focus on is developmental screenings. And this is something that a lot of childcare programs have started doing. We know that all the kids have a screening with the Brigance when they enter kindergarten. So, a lot of our childcare programs are trying to help families get familiar with that process, learn to read the information in advance, kind of familiarize the kids so they don't feel awkward in that process. Developmental screenings are usually with a certain tool. So a company may make a developmental screening. We get a small amount of training on it. And then there's regular intervals that the American Academy of Pediatrics recommends that we do assessments at, like 9, 18, 24, 30 months. A lot of those big transitions, like at 18 months, that's a big transition from moving out of the infant toddler and getting closer to that 2-year-old age. Are we on track to be using our words and those kinds of things? And we see screenings are often used by healthcare professionals. Any of you who are parents and have taken your kiddos in for their checkups in the first 2 years, you get like a little developmental checklist sheet on your check-in information, and it says, does your child use words? Do they point? All kinds of different things to track their development. But in recent years, we know that teachers are using those tools a lot. And it's helping us to identify a lot of those kiddos that need support before they get to kindergarten, actually, maybe even before they're out of the infant toddler room. And so they can get that early intervention as soon as possible. And that really puts us on track to help support and then get them ready to get intervention so that they are at a place where they're ready for kindergarten. So if you're using a developmental screening tool, these are probably the four most common. And I just want to give you a little bit of information about each of them. So the CDC, if you go to their website, they have developmental checklists for free. And they have brochures that go along with those age groups that are called milestone moments. They're great to photocopy, send home to parents. The cool thing for parents is that there's a free app called the Milestone Tracker, and it gives information to parents at each age on things they should be looking for. The American Academy of Pediatrics has something similar to this too, called the Healthy Children, Healthy Child app. And when parents log on, they just put in their child's age, their birth date, and then they'll get notifications from the app on, your baby is 6 months old today. These are things that we look for a 6-month-old to be doing. Your baby is 2 now. These are what we expect a 2-year-old to be doing. And so that CDC information and the Healthy Children, those are free resources, and they can be used both in the classroom by you and parents at home. One of the most common screening tools that we see in classrooms now is ages and stages. This is a really well-researched tool. It has a very small cost. It's about a one-page screening tool. It looks at every developmental area. Um, Teaching staff can get a very short training on how to use it. And now even we're seeing like our children's librarians in some counties are getting trained on how to use ages and stages for kiddos who might not go to childcare or preschool. If they stay at home with a parent before kindergarten, then the children's librarian might be able to screen them when they're at circle time. One, on a Tuesday morning afterwards, they'll do a screening. And so the parents can have some information. And I know that Metro United Way in Louisville has done a huge push across Louisville to get ages and stages in the hands of all kinds of professionals to get some of this initial screening. Once you sign up to use Ages and Stages, there's tons of resources on their website. They have some things that you can send home to parents as well. So it is pretty simple. Like I said earlier, the Brigance is the screening tool that Kentucky has designated as pre-kindergarten. And again, it's not extremely expensive. We focus on using the pre-K one for the kiddos who are getting ready to go into kindergarten, but they have Brigance screenings for as young as 3 months, 6 months, those younger kiddos too. So it's something that you can use for your whole program. Again, brief training for teachers, but a lot of resources online. The wording is pretty easy for parents to understand. We try and get away from lingo that can be really confusing for families. We want to make sure that we're not using jargon from the education field and really explain, can your child walk up the steps with every other foot instead of using the same foot? Those kinds of just plain descriptions that will really help them. Many of you, if you use teaching strategies as a classroom curriculum, may be familiar with their screening and assessment material called Teaching Strategies Gold. This costs a little bit more because it's usually like a package with the curriculum. And it's what we call a curriculum-based assessment, not just a screening tool. So we think about all the things we would teach in the classroom. Teachers have a different account for each child. They can go on the computer and log on and say, yes, they can cut in a straight line with scissors, but no, they're not quite ready to cut a crisscross pattern or, a shape out, things like that. You observe in the classroom, you use the assessment tool, and then you use the results of that assessment to create your next activity. Since it is based on curriculum, it helps teachers be set up to a place where they can say, okay, almost every child in my classroom isn't using scissors really well right now. So we need to do some fine motor activities that will help prep kids to be able to use scissors more effectively. So maybe now we'll practice tearing paper. We'll do different things that will prepare kids to be able to use scissors. And we want to make sure that they're out in the free art area so that they can start to learn to manipulate those. Maybe you use the squeeze scissors first before you use the ones where they actually have to put all three fingers in the correct place and manipulate. The Teaching Strategies Goal does a really really good job of linking the developmental milestones with the curriculum. So you're planning curriculum based on the needs of the classroom and not just based on last February we did this. So in my classroom this year in February, we're going to do the same thing. We want to make sure that it's focused on the needs of the kiddos this year. With any good screening tool, you're going to have 4 different buckets of where kiddos land. You'll find some kiddos that have above average results, that everything that you're currently doing in the classroom, they're surpassing. And so you've got to think about new ways to challenge them. That means if you're teaching a 3-year-old class and you've got somebody who's meeting all the 3-year-old skills, you need to think about what are 4-year-old skills and begin to challenge that child to their best potential. You want them to be as successful as they can. We're going to have kiddos that are meeting the developmental milestones. They're cruising along at the pace that we really anticipate, and they kind of fall into the curriculum naturally. We're going to have other kiddos that might have a delay, just a slight delay in 1 or 2 areas. Maybe they've got really good gross motor skills, but their fine motor skills are lacking a little bit. We're going to think of ways like using Play-Doh and clay in the classroom, doing some puzzles, getting out that old light bright and putting the little light bulbs in just to improve their fine motor skills. And once we, get the curriculum ready for them, then they start to excel. The fourth bucket is what we're going to talk most about tonight, and those are kiddos that you're starting to see that there are significant delays in one or more areas, and we're thinking, okay, they need some help. What we're doing in the classroom is not enough. They're going to need more individualized support, and that's when we have to think about what our next steps are. So, when you have a kiddo that you can tell has a significant delay, what do you think are some of the steps that you take next in your classroom setting? You can drop stuff into the chat and say, this is the first thing that we do to help a child in this setting. Who do you talk to? How do you address it? So talk with family. Yes, family is one of the very first things that we need to involve once we um, realize what's going on. But how we talk to family is very important. We've got several people who say go to a director. Essential to incorporate the director into the discussion, particularly since some parents struggle to hear negative news, and you want your director's support when you have tough conversations. Um, This is a very sensitive, yes, this is very sensitive, somebody says. It is a really tough conversation to have. You are telling somebody that their precious baby is not perfect. And as a mom myself, that is a hard conversation to hear. So we want to make sure that we are sensitive with information and we address it as quickly as possible, but also as empathetically as possible. And others I see on here have referenced public school, preschool, First Steps. Well, the organization formerly known as First Steps. Now it's the Kentucky Early Intervention System. But you all know some of your resources, so that's fabulous. We're going to go on and kind of talk about what the model is usually once we decide there's a concern. So the first thing that I would encourage you before you have any conversations is to have documentation. Detailed, objective observations. So when we talked about anecdotal notes earlier, I want everything to be as factual as possible. Say the child was building a block tower, the child put 5 blocks in a row, they fell down, the child began to cry. As much emotion as you can take out of it is going to really be helpful when we show that to the family because they don't want it to seem like your opinion was involved in any way. They want to know facts. So thinking about how we do multiple observations with data, and we use those screening tool questionnaires to show like maybe a red flag in certain developmental areas. And we have that documentation ready before we have the hard conversations. When we go and have those hard conversations without documentation, people just have so many questions and there's no data there to help answer their questions. So we want to have that ready and prepared. I would always encourage you to speak with your director or supervisor first, let them know about your concerns and how you plan to move forward. Some families are a little more fragile than others, so sometimes directors would like to sit in with the teacher when you have the conversation just to show that they have your back. Other times they just want to be prepared in advance to know if a family is going to come with complaints or just come and be overwhelmed and say, I got all this information. I don't know how to handle it. Are you seeing the same thing that the teacher is? And a lot of times our directors were in the classroom first and they have years of experience. So they're great references for a parent who's trying to process all this information. Once you've talked with your program director or supervisor, then it is important to talk with parents in a very timely manner. I will always encourage you to talk to parents in a parent-teacher conference one-on-one. Do not let these kind of big conversations happen at drop-off or pickup or when people are coming in and out of the room. You want this to be confidential information that parents have the time to ask a lot of questions if they need to, because it can be a lot to process. We're going to share notes and observations to give them that factual information, provide resources. Many of you said keys, first steps, public school, preschool, things of that nature, and then just really show all the support that you possibly can for the family. I'm here. I'll do what I can. I'll fill out evaluations, whatever it is that I need to do. Is kind of the one, two, three of this process when we're looking at referrals. So again, how do I support parents? Come with as much information as possible. And that is really going to help them when they go to talk to people. If they have to talk to a pediatrician or a therapist during an evaluation, if they have your notes or the work sample that you put together, then that's going to give them concrete information as they share your concerns with somebody else because they're kind of the middleman in a lot of this. You're seeing a lot of it because you're with that child for 8 hours a day. Parents don't see them in the same settings. And often, a lot of times at home, parents are helping children more individually. Um, so they might not, a small child can just point at a cup and mom gets it for them. Whereas in the classroom, we're going to say, no, you have to use your words. So there are things that we're noticing that parents might not just because the groove of the evening. And a lot of times, being a working mom myself, when I went to pick my kids up, we had a very structured end of the day. We had dinner, we had bath time, we had a bedtime routine. We got into bed, and then all of a sudden, my time with them is over. But I didn't get to see them in a lot of those educational settings. So it's really important that that information that is shared with them. You really want to give parents your full attention while you're having this type of discussion. So find a place outside of the classroom to talk to them. Ask the director if you can get a sub to be in your room. So you're not worried about nap time if kids are sleeping and you're having a conversation. It's also really good to have a beginning and an end time. That way, if parents do get upset, you have a hard stop. You can wrap things up and say, these are your concerns. We can meet again and talk about them. But for a parent who might be in denial or get angry, you know that you're not kind of stuck with just an open-ended time period that that could go on for much longer than necessary. Um, Again, showing empathy and support is essential, even if you've never been in a setting where, you don't have a child of your own, or you've never had a child that has gone through this. Just showing your support and that you are concerned and care about the child and you're willing to help the family does a lot to help them accept the information. And then providing resources. A lot of times, what teachers can do in advance for any family is provide or like create a resource list with contact information for both the early intervention system for birth to 3, public school, preschool, and then even like local private pediatric therapists. If insurance is going to cover it, then you can list 3 or 4 places in the area that they could call and get an evaluation there if they're going to take that route instead, because sometimes parents just don't know where to look. And many of you have worked with kids who parents have given favorable recommendations to who they worked with in the past. So you hear a lot of that information that maybe parents haven't heard before. So having that resource list available and being able to give them in a one-pager can really assist as well. So one of the big things that I want to talk about is noticing. When we're sharing information with parents, many of you, I've worked in the field of early childhood ed for 27 years. Some of you may have surpassed that. Some of you may be close to following me. You could be newer in your career, but a lot of us have seen cases where we have watched a child and we're like, I know exactly what that is. I'll bet you $10 when the parents come back and tell me the results of the evaluation that I was right. Thing about it is, none of us are diagnosticians. We don't have medical degrees. We focus on the education, but not the diagnosis. And so a teacher or director never should diagnose. The problem is if that goes wrong, first of all, doctors have malpractice insurance. And so if they make a wrong guess, they have somebody to cover their behind. We don't in the early education field. And when we go out of our way and say we think it's this and it doesn't end up being that diagnosis, then parents can have a lot of hostility towards us, and we're still the one who's spending all day with their child. And so we don't want to put um, the child's care in a bad situation because there's a bad relationship between the parent and teacher. So what I always do is that I notice. When I've talked to parents, I say, I've noticed that this is happening. I've noticed that he's tripping over his feet a lot when he walks down the hallway. I've noticed that he has a hard time going up and down the stairs, and so he starts crawling instead of walking. I've noticed that this is happening. Have you noticed these things too? Okay, well, maybe it's time to talk to the pediatrician. I pretty much always refer them to the pediatrician and let the doctor handle it instead of me. But I do want to make sure that I document everything I've noticed, how often I notice it, what days I've noticed it. And then we let the specialist have the very hard conversations where the actual diagnosis happens. And that may be a specialist through the public school system if they're a preschooler. It may be a specialist through First Steps or Keys if they're young, or it could just be the doctor themselves is diagnosing. But it really is key that no matter what happens in the early childhood classroom, we notice instead of diagnose. How many of you have had a parent get angry with you when you have suggested that their child is struggling in a developmental area? If you haven't had a parent get mad at you, then you probably haven't had a lot of tough conversations yet, because it's natural that we don't necessarily want to handle tough news. Some parents come to you, and when you give them information, they're like, what do I do? How do I fix it? What do I do next? And they're hungry for information. And others are not ready to hear that type of discussion. So it's pretty common that one of the most popular responses for parents is to deny it or to be angry. It makes it hard for us because if we have a child that has really challenging behaviors and we're trying to talk to the parents about an evaluation because those behaviors are making it hard to keep that child safe, to keep other kids safe. We know that the child isn't going to be ready for kindergarten because of it. It can be so frustrating when you go to the parents and they don't want to pursue anything at this point in time. One of the things that I want to remind you, whether it's in early childhood or whether it's in the K through 12 school system, if a child is evaluated and they find that there is a diagnosed disability, parents have the right at any point in time to decline services. They also have the right to decline an evaluation if the public school system comes to a family and says, these are our concerns, we'd like to have your child evaluated. The family can say no at any point in time. There are often cultural beliefs, and I don't mean religion or people from different countries or anything like that. Even within Kentucky, we have a lot of different cultural beliefs on whether or not therapy is supportive or whether or not we do therapy. Our family doesn't do that. We don't need help. We pull ourselves up by our bootstraps kind of thing. And so there's a lot of different cultural beliefs on whether or not I want my child to be involved in therapy. We also have a lot of parents who went through the special education system themselves when they were children and had really negative experiences. And they don't want their child to have that same type of experience. And so they decline early intervention because of that. Now, what they don't know is that when you are in a 0 to 5 classroom and a therapist comes in to work with kiddos, the therapist is the most popular person in the room. Everybody is hanging on them. Everybody wants to hang out with the OT and go down the slide on their belly. And it's not, um, there's no judgment attached. There's not any type of labeling. We see that a lot in K through 12, but the great thing about early intervention is that those stereotypes can be avoided in some ways. And the child may not need intervention after the 0 to 5 classroom. But parents, in a lot of cases, don't know the difference in that special ed experience of K through 12 and early childhood, and they want to prevent their child from having a lifelong label or from feeling singled out. So there are lots of different reasons that a parent may decline services. One thing to keep in mind, though, is even if the family doesn't feel like they want services now, it's important that we plant a seed because maybe in the 2-year-old room, they said, okay, we hear what you're saying, but we don't feel like we want an evaluation. And then they hear the same thing again in the 3-year-old classroom, and they're starting to be like, oh, I don't know, but I still don't think that he needs it. He's fine. And then by the time they're in preschool in the 4-year-old classroom, when the teacher approaches them, they're like, well, we've been hearing this for a while. There's probably something to it. We need to look into this more. So sometimes maybe you're the first teacher that comes to them with this information and you've planted a seed. But we know that eventually down the line, when they begin to hear the same types of comments over and over, that they may realize that their child needs a lot more support and they'll be willing to accept services at that point. Um, so there are things that can help them out, even if they say no to you. Um, some other things that I want you to think about when we're in that initial parent-teacher conference and we're telling parents about what type of resources their family may need and those types of things. Many of you know that there are limited resources when it comes to pursuing evaluation. I think right now in Kentucky, we have around 50 child psychiatrists, and 25 of them don't take insurance. They're cash only because they got tired of fighting with health insurance companies that wouldn't cover the prescription that they wanted or things like that. For an autism evaluation at U of L, UK, um, or Cincinnati Children's Hospital, you're going to have a wait of at least 18 months in most cases, and sometimes even longer, depending on what season it is and how many people are referred. So if you do talk to a family and you tell them, hey, we need to you need to have further evaluation, just remember that they can be really frustrated when they're in this holding pattern, waiting for so long to find out any information. But while they're waiting, the challenging behaviors don't stop. The the delays can often become even greater compared to their peers because it can take so long for evaluations, depending on what services that you need. And that's where a lot of times parents can become almost depressed um, because they don't know how to help their child during that waiting time. Um, for me as a parent, going through the referral and evaluation process, waiting for that evaluation was one of the hardest things that I had to do because I knew what the evaluation was going to say. I was determined I knew what it was going to say. I needed the health insurance company to know what the evaluation was going to say so that it could start providing the services that I need. But it went on for over a year before we got everything that we needed. And during that time period, I watched my child struggle. The other thing for parents to keep in mind is that this is a long journey. And once you finally get that diagnosis or that evaluation, that's just the start. It can be a huge relief to know, okay, I have a tangible idea now of what's going on. This is what it is. It's a delay in this area. It's this condition. It's this medical terminology. But that really is the starting point because just knowing what it is and getting the therapist that I need doesn't mean that the behaviors are going to be fixed soon. Therapy is a long time process and it can do amazing things, but you have to be consistent. When families go once a month and cancel 3 times a month, we don't see progress. So there's a huge road in front of them. And we want to be very encouraging during that time period because um, a lot of people get so excited that they finally got their evaluation and they finally got um, the counselor, the pediatric therapist that they need, an OT, PT, speech, whatever. Um, but there are a lot of steps down the road after that. So we want to continue to support parents during that waiting time, and we want to help them stay encouraged as they start a long journey with therapy. Where to find resources? Like I said, for me, if the family has a pediatrician, I often ask them to start there. directing them to somebody they trust that they already have a relationship with who has medical background is a great place to start, just because we know that they have some connections there. And again, somebody who's trained on medical procedures can talk about what we think this is, who you think you need to go to. Now, the tricky part is a lot of times that a lot of our families don't have a medical provider that they see regularly. Maybe they go to the health department or something like that. So they don't necessarily know who to go to. But the great thing is that when you're looking for evaluation and therapy through one of the public resources, you don't have to have a medical provider make the referral. So that means that if you go through KEYS, which was formerly First Steps, or if you go through the public school system, you don't have to have a doctor involved in the process. There are staff there that can do the evaluation and everything. And those resources can be free. Or families that want to use an insurance-based service have that option as well. So let's talk a little bit about KEYS. Used to be called First Steps, if you aren't familiar with it. So this is for the birth to 3. Now, a lot of times if a child is born with a medical condition, like a child is born with Down syndrome, they're going to get a referral to First Steps automatically, because they know that that medical complication will have some therapy-based needs. It'll come with some delays. And so a child could start right off as soon as they are old enough to interact with a therapist and get that referral really quickly. Others can come through time. But the cool part is that a parent can make their own referral to First Steps. The doctor can, or a teacher can. If you're working with the family and they don't know exactly what to do, then you can say, well, they have like a one-page sheet for referral that just says what your concerns are, contact information for the family. I can help you do this. It is not a big deal. And so that referral process can be started very easily. Since Kentucky's First Step system, the KEY system, is part of IDEA, the Individuals with Disabilities Education Act. There are specific timelines that they have to meet from the time that they're contacted to when they have to do the evaluation to when they have to get a response to you, just like the public school preschool program. So parents don't have to wait indefinitely and not know when somebody will give them information. So that's also very comforting. For a long time, First Steps was completely covered by the state, but as we know, things like health insurance or that are related to health insurance have gotten more and more expensive. So if a family has health insurance, they will charge the health insurance first, and then the KEYS program will try and cover the rest. Parents over a certain income level, though, may have to make some type of a monthly copay, but it's really manageable. The largest copay that I've seen for a family, I think, was $100 a month, and they got weekly services with the First Steps provider. Now, here's the best part for early childhood providers. For First Steps, therapists will visit the child in their natural environment. So if a child is enrolled in a child care program and spends, 6 to 8 hours there a day, then they will often come to the child care program to do the therapy with the child in a group setting. As an early childhood provider, you can watch what they're doing with the child, learn how to do those types of interventions so that you can support the child even when the therapist is not there. And a lot of those same interventions work with almost every child in the classroom. So they're great tricks to learn. It's like free technical assistance for your classroom to work with children who may have a disability or a developmental delay. So that is absolutely awesome. As long as the parents give permission for them to come to the program and work with the child there, then it's just such a great tool. Some parents really want the therapist to come to their home, and so they set it up so that they'll come to the home. Maybe they stay home late one morning a week and they do that there. But this is a really great service for a lot of working parents because once you've worked all day, it's really hard to run around town and find a therapist's office that will stay open till 6 o'clock, till 7 o'clock. And having a First Steps provider that will go to the child in their natural environment, in the child care setting, is just an amazing resource, which is one of the reasons that I just adore our Kentucky Early Intervention System. Similar to that, for kids in the 3 to 5 year old range before starting kindergarten, public school preschool offers the same kinds of therapy. Parents can request an evaluation from the local public school once the child turns 3, or if they're in first steps, right before they'll turn 3, they'll kind of transition them over and prepare along that lines. Now, with public school preschool, the difference is there are no services in the summer, whereas First Steps does year-round support. Again, there are those distinct timelines with, 45 days from this point, we have to have the results of an evaluation. We have to tell parents by this point, therapy has to start. So that's fabulous compared to some of the private medical facilities that make you wait forever and ever and ever. With this, we look for children to qualify for public school preschool when they're 3 or 4 years old, or a young 5 who doesn't qualify for kindergarten, and they have a delay in one or more areas, a significant delay in one area, or a milder delay in 2 or more areas. And then they can enroll in the public school preschool program, which the base for all programs is 3 hours a day, 4 days a week, but some counties offer more. And during the preschool day, they will get their therapies. Now, it is possible for a child, a family to turn down the actual preschool and just go to the school to get the therapy, but you would have to work it out with the district at what day and time that would occur because the therapists often have um, very full schedules. A lot of kiddos will utilize the half-day preschool to get their therapy and then go to a child care program afterwards for the remainder of the day, because these half-day programs are often like 7 to 10 or 11 to 2. And then the child would need care for the remainder of the day. Sometimes they start off at the child care program, go take a bus, or the parent comes and gets them to go to the 11 to 2 program, and then they come back afterwards. I will say that it can be a little overwhelming for kiddos with behavioral disabilities to transition back and forth all the time during the day. And so either starting off at one place and just making one transition to the second, or thinking about how to get therapy maybe on one day, set up with the school district, and then enroll in full-time childcare may be a better option depending on how well a child handles transitions. Because all of us have a little bit of a hard time with transitions, but some of our kiddos have a much more challenging time. Now, for those who public school preschool might not be an option, all those transitions are really challenging, and it's hard to just bounce back and forth from place to place with different teachers and different rules at different places. Some families opt to get private evaluations and get therapy through their private insurance or pay cash for it. In these settings, typically a doctor referral is needed because most insurance companies will require that um, to to say, yes, there's an official evaluation. The doctor has said we need it. And then once the evaluation is done, they will um, recommend what services are needed. One benefit of private pediatric therapy is that they will often take kids that don't quite meet the threshold for the Kentucky Early Intervention System or for the public school system. So if the child has milder delays in a couple areas and they don't qualify for state services, insurance will probably cover those services and can support them. Insurance companies do frequent reevaluations, like every 6 months, to make sure that the child still meets their um, qualifications for needing assessment if they're just in the developmental delay category. But if a child has an official autism diagnosis, particularly in Kentucky, we've passed laws that say if you have an autism diagnosis, you get, much more occupational therapy with your insurance, much more speech pathology, those kinds of things. You send that letter into their healthcare provider, the number of visits that they have that are covered go up, and then the family um, doesn't have to go through that reevaluation process all the time because they have that medical diagnosis in place. Often families have to pay a copay with insurance, or if they're paying cash, then they pay the entire cost of service, which can be overwhelming. And so that's where keys in the public school system definitely have an advantage. And these services are typically only offered at the therapist's office. Although I will say, In several counties that I'm aware of, there are certain pediatric therapy offices that have relationships with local child care programs, and maybe they come every Tuesday, and all the kids that need therapy are assessed so that they can get those services on Tuesday at the child care program. And they've got kind of a relationship with that. I saw Jessica Groves was on this training, and at her child care program, they worked out a deal with another a pediatric therapy organization in Lexington, and they came like twice a week just to work with all the kids who knew that they needed therapy. They went through the evaluation process with the therapist's office, and then they lined up the appointments and had a very symbiotic relationship there to make sure that kids got the support they needed in the natural setting, and the teachers also got to learn from the therapist. So those things can be huge, huge benefits when you have those partnerships in place. Again, like I said, waiting for diagnosis and services can be so stressful for a family. And when you have a child who's continuing to show aggressive behaviors or challenging behaviors, hurting themselves, hurting others, continuously fighting with you, and you're in a holding pattern, you don't know when you're going to get the support that you need, that can be a huge risk increase for abuse. Because the family knows that there's something wrong, but they feel stuck. They don't know what to do. And that's when teachers can really step in and give families ideas on ways that they can support their child at home. You can have parent-teacher conferences about, we're doing this here. It would be great if you did it at home so that things are, um, the same in both settings. And then the child begins to understand the rules and they have consistent behaviors. One of the things that I ask everybody on this call to think about is, and remember, is that children with disabilities are 3 to 4 times more likely to be abused. And that can be by a parent, grandparent, mom's boyfriend, caregiver. It can also be from child care providers in some cases. Um, when I first started teaching and I saw the statistic that children were more likely to be abused when they had a disability, I thought it was children maybe that couldn't speak and so they couldn't report abuse, or children who were non-mobile and so they couldn't necessarily get away from their abuser. But what we actually see more often is children with behavioral-based disabilities like autism, ADHD, things of that nature, are really the ones that are more at risk of abuse because it puts such a great amount of stress on the caregiver. Um, and now that I'm a parent experiencing that, I understand that it's tough. And some of
I even slept with a few of them too, but
there we go. Okay, thank you. Some of the things that we have to think about are how we handle those negative behaviors, having a negative behavior plan in the classroom and then sharing that with parents so that maybe we can give them ideas for at home. But one of the biggest things that we really want to help parents and caregivers with, whether it's mom or dad raising the child or whether it's a grandmother, foster parent, whoever, is thinking about who their support system is and reminding them that it is okay to take breaks. When a baby doesn't stop crying for hours on hours, reminding mom or dad that it's okay to leave them in the crib crying, that they will be safe if mom or dad need to walk away, just so that they can have a good headspace and learn to cope with the stress of hearing a screaming child all the time. When you have a child maybe with autism that's aggressive and the caregiver is getting hit or bitten or things of that nature, knowing that they have a time where they can have somebody else safely watch their child and they can have time alone. Those kinds of things are huge. Helping them to connect with like local churches that might have a parents' night out, or organizations like Critically Loved, Feet of the Bluegrass, some of our Down syndrome associations, some of those groups that have parents that are going through similar things and helping them connect with families who understand what they're experiencing so they have somebody to vent to, um, can be huge as far as making parents feel supported and loved. Um, and one of the unfortunate things that I always need to remind everybody is that teachers are mandatory reporters. So if you suspect that a child is being abused, it is your obligation to report that it's possible abuse. You do not have to know that it is abuse. That's the job of the DCBS investigator. You just have to see signs that are making you worry, and you know that you need to report them. How your center handles that can vary. A lot of times the center may ask that you tell the director and that you make a joint report, but anybody is able to make an anonymous child abuse report if you don't want to have your name attached to it. It's always better when you do have your name attached to it so that they could call you back. As a teacher, you have constant contact with that family, and they can get details from you, and information that you share can be really important. But one thing I do want to tell you is if a director says, tell me, and I will make the report, and then that person doesn't report and you knew of possible abuse, it can come back on you. Whoever sees it needs to be the one who reports it. Because sometimes if you pass that off to somebody else and they don't report, then nobody ever reports, and a child could be more significantly injured. And of course, if you ever hear somebody on a child care staff tell someone else not to report what could potentially be abuse, please disregard that comment. If you're concerned, then it is essential to report the potential abuse case. Another thing that I want to talk to you about is expulsion. Preschool students are expelled from child care programs 4 times more than children in the K through 12 school system. Anybody have any ideas on why that may be? This is a great time to throw something in the chat. Why do you think preschool kiddos are getting expelled more than our kindergarten through 12th graders? No resources. Christy, you are absolutely correct. The school system has more support, more behavior problems. Low staff, yes. So in Kentucky and everywhere throughout the United States right now, we are operating at a lot of maximum ratios. It is really hard to have lower ratios because you don't get the income that you need to run your program. So that means that in Kentucky, 1 adult can be left alone with 10 2-year-olds. 2 adults are in the room with 22-year-olds. And what if 2 of those kiddos have autism? What if you have somebody with significant sensory issues that is biting anything that stands still? Directors often have to make a choice. If I'm working at maximum ratio, I don't have anybody else who can support in the classroom, then I have to figure out if I'm going to lose a lot of families, if kids are going to get injured, or if my teachers are going to leave because it's so stressful. And right now, great childcare teachers are hard to find. You all are precious. And many directors would rather lose a student and bring in somebody off of a wait list than lose a teacher who can care for 10 children, 12 children. So we see that challenging behaviors, often associated with a disability, are the #1 reason for expulsion in preschool programs. And it's not, hey, you're expelled. It's not a director sitting down and say, we don't want you, you're expelled. What it often is what we call a soft expulsion. And a director will sit down with a family and say, I'm worried about your child. I don't feel like this is the best place for them. We don't have the staff needed to make sure they stay safe and that nobody gets hurt. And I honestly believe that when directors tell a child that they are being sincere. I've never met a director that wants to expel a child. I've never met a director that wants to have that kind of hard conversation. But childcare programs don't have special ed departments. They often don't have a lot of floating staff. And so when a child has really extreme behaviors, a lot of times it is a tough choice. Maybe your child needs to be in a smaller classroom. Maybe your child needs one-on-one care if they have a significant disability. But what I challenge you to do, instead of getting to the point where a child is expelled, is creating a center policy on how you handle challenging behaviors instead of automatically opting for expulsion. So as a past director, one of the things that I tried to do is when we had a student with repeat challenging behaviors, instead of expelling a child, We would sit down with the family and say, okay, these are the challenging behaviors that we're seeing. We really encourage you to go take your child for an evaluation. If you have your child evaluated and you're pursuing therapy and you share that information with us on how we can work with them in the classroom, then we'll keep the child enrolled. But if you're not going to partner with us and you don't want to go through the evaluation process and get that therapy support, then this is probably not the best place. Um, but think about how you could create a plan to support those negative behaviors before you ever get to the point where you're thinking about expulsion. And I will tell you, for anybody who has really severe biting policies, all of you know, if you've ever worked with young children, that biting is a typical behavior. It occurs. And we're going to see some bites. If you teach in a toddler room or a 2-year-old room, you are going to see some bites. If you're seeing bites in the 4 and 5-year-old room, then there's some significant things going on there that probably need an evaluation. But with our young kiddos, we know that it's normal. Every year we have to calm parents down. The 0 to 3 website, which is literally, you spell it out, 0 to 3. So ZEROTOTHREE.org has great handouts about developmental milestones, but they also have a wonderful handout that I ended up sending out every year I was ever a director about why biting is normal and what occurs with biting and how we handle biting and ways to decrease biting. So I would encourage you to look at some of those resources and help explain to parents that biting is normal. Your child will survive if it's just a few times. If it becomes a child targeting one child constantly, things like that, then obviously there's greater issues. But I would encourage you to look at policies that don't automatically suspend or expel children for just a handful of bites at one time, because that does get really challenging. Ultimately, all of this is very overwhelming for families. And the idea of having a child that you dreamed of for years, you wanted to have, and you had huge plans for, and then all of a sudden being told they're not perfect can be really, really overwhelming. So many of us, when we get pregnant, we start thinking about, oh, this child, this baby that I'm going to have, they're going to be president of the United States and a ballerina and a national or international soccer player. And we have all these huge, huge hopes and dreams. And the second that somebody says your baby has a disability, your child has a delay, then we automatically go through this point where we're mourning the life we dreamed of for our child. And that grief can come back and hit you at different points. It can be cyclical. You might get through the initial diagnosis, but then once the child starts kindergarten and you start seeing more significant differences, or once, children become more independent, but your child still has to have one-on-one care in a lot of settings. Just there are times in life when it's going to come back and affect parents differently. But I want to share with you this poem. It's called Welcome to Holland. It was written by Emily Kingsley, and it's a description of what parents go through when they find out that their child has a disability. So here it is. When you're going to have a baby, it's like planning a fabulous vacation trip to Italy. You buy a bunch of guidebooks and you make wonderful plans. The Colosseum, the Michelangelo David, gondolas in Venice. You may learn some handy phrases in Italian. All of it will be so exciting. After months of eager anticipation, the day finally arrives. You pack your bags and off you go. Several hours later, the plane lands. The stewardess comes in and says, "Welcome to Holland." Holland, you say? What do you mean, Holland? I signed up for Italy. I'm supposed to be in Italy. All my life, I have dreamed of going to Italy. But there's been a change in the flight plans. You've landed in Holland, and there you have to stay. The important thing is that they haven't taken you to a horrible, disgusting, filthy place full of pestilence, famine, and disease. It's just a different place. So you must go out and buy new guidebooks. You must learn a whole new language. You will meet a whole new group of people you would never have met. It's just a different pace. It's slower paced than Italy, less flashy than Italy, But after you've been there for a while and you catch your breath, you look around and you begin to notice that Holland has windmills and Holland has tulips. Holland even has Rembrandts. But everyone you know is busy coming and going from Italy. And for the rest of your life, you will say, yes, that's where I was supposed to go. That's what I had planned. You may spend your life mourning the fact that you didn't go to Italy. You may never be free to enjoy the very special, the very lovely things about Holland. But we have to remember that Holland is a wonderful place to be also. So many of our parents go through mourning when we start to have these discussions with them. And so I just want you to think about the grief that they experience and what they're going through and how we can support them as they deal with this flight plan change. They thought they were going to Italy and now they're in Holland and they have to regroup. The stress is a little bit higher, but once we learn to cope with things, it gets a little bit better. It's just hard to figure out at first. So what I'd like to do now is open the floor up or the chat up to questions that you may have. It could be situations that you've had with parents. It could be trying to figure out referral processes for kiddos who have different situations, or maybe you're in a rural area where resources are not quite the same. Um, so if there are questions, I'd be happy to help you with those at this time.
There, while everyone is putting questions in the chat, I just wanted to flag that I did see a question. Someone asked, how do private schools differ from public schools in terms of getting services?
Okay, great question. So private schools are much like childcare.
That's either till you start being nice to daddy.
Private schools are much like childcare programs in the fact that they do not receive IEP services. Um, and special education funds. So what the private school does is really up to them. I have a son in high school that attends a private school in Lexington right now. They have kind of a special ed resource room, and they ask that you bring your IEP that you had from the public school, or if you've been evaluated by a private facility, that you bring that, and they'll offer support. A lot of private schools have started to incorporate learning disability supports for kids who are struggling with reading, math, things of that nature. But it is pretty unusual for them to do support services for a disability like autism, because that is more behavioral based. I do know that a lot of private schools will try and work with you if you bring in information from their therapist on strategies that would work. A lot of it will come down to their staffing availability. Any other questions at this time?
I think it's important to note that kids coming from Keys to public preschool don't always qualify because the at-risk medical eligibility. And so I find a lot of parents are disappointed because they were told if your child's in first steps, they're going to be able to go to preschool.
Mhm. I will agree with that, Beth. My oldest son was in first steps. He had some motor delays, balance issues. He did not qualify for public school preschool, so we had to, when he transitioned out of Keys, we had to pay for private therapy and get him the support that he needed that way. It was not automatic that he would qualify by the public school standards.
There, we have a couple other questions too in the chat. The first one that I saw, someone asked, what about things like lazy eyes? It seems to be more of a medical thing, but I know that the parent hasn't really worried about that.
Mhm. Well, there's a variety of disabilities, and all of our schools do some vision testing. And we have programs in Louisville and Lexington, like VIPS, visually impaired preschool services. And so, in those cases, vision services are very specific. I would always refer the family to an optometrist first. But then there are services that special education through the public state service systems can offer. And in some places, okay, so like I said, visually impaired preschool services is both in Louisville and Lexington. In those, in cases like in Louisville, the public school system, the public school preschool has spots that they reserve that they partner with VIPS to offer for kids who qualify for public school preschool services but need vision impairment support. So there are some services that those families can get, but it would start with a medical evaluation.
Okay, another question I saw was, how do you send a referral to public school? I usually talk to Head Start because our county is blended, but having trouble getting to public schools.
So with public school, the best way to start is to have the parent contact their local elementary school. So if they are in district, my children's school is like 2 blocks away from our house in district. If you contact them, start with them, then they can start the process of the paperwork. Or you can contact the district's preschool services office. Like if you go to the main county central office, they typically have a preschool director who might also be the special ed director, since preschool services are predominantly for kids with disabilities. It could be the same person, but you can contact that central office contact as well. But for the most part, for those public school services for 3 to 5, the parent will have to initiate that. But with First Steps, the teacher can assist and just contact the local First Steps office, and then they'll help with that one-page referral. I will say, she brought up Head Start in her contact. Head Start programs typically reserve 10% of their slots for children with disabilities. The normal way to qualify for Head Start, or the most obvious way, is if the family lives at the federal poverty level or below. But some of those slots are saved for kiddos with disabilities, both in early Head Start, which is birth to 3, and with Head Start, which is 3 to 5. Head Start has amazing wraparound services. They do things like provide formula and diapers and parent education and immunizations and dental visits and things. And so if you have a family that really needs those wraparound services and that would qualify for Head Start, that can be an amazing resource for them. And it may be that you don't have the resources to support them. So particularly when families reach out to me if they've been expelled from private childcare programs because of challenging behaviors, I often refer them to the local Head Start, because Head Start has a strict policy of no expulsion.
Okay, I saw one other, and then I just lost it. Oh, for a student in a 2-year-old class who shows mild signs of autism / very high functioning, is it worth bringing up to the family being so young?
So most children who are diagnosed with autism are diagnosed under the age of 3. Now, not all, but most. There's a good chunk. Signs start to emerge as early as 18 months. I would never tell the family, I think you should be evaluated. I think your child should be evaluated for autism. Again, I would say, I've noticed that your child doesn't interact with other children. I've noticed that they have a very hard time when we change what we're doing. I've noticed that they have a lot of anxiety in social settings, or they get really upset if there's a substitute in the room. Try and outline those characteristics, but 18 months to 3 years is a pretty typical age range for an initial evaluation for a lot of kiddos who have autism. Any other questions?
Sarah, could you talk a little bit more about creating policies around handling challenging behaviors?
It is really hard to create a blanket policy too.
It really is.
And I know, Laura, you've had a lot of blanket policies. That's why I usually go with an initial first step of a behavior plan. When a child has a disability or extremely challenging behaviors, I want to get a plan in place with the family. If a child comes in, they tell us they have a disability, or they tell us they have a chronic health condition, then I set up a disability plan, or I used to when I was a director, and say, okay, these are the accommodations that we need to make. This is what we need the family to do. You know, if the child has epilepsy, You know, when we're here, this is what's going to happen. A lot of people who are diagnosed with epilepsy don't want you to call 911 when they have a seizure because they'll pay for an ambulance, go to the hospital, and they'll say, congratulations, you had a seizure, which makes sense since you have epilepsy. So the family may come in and say, okay, with this medical condition and this disability, these are things that we want to happen. We sign off on it. We agree to work towards it. When what is in that plan isn't happening with the family anymore, that's when we have to sit down and think about whether or not we can care for the child. Challenging behaviors are kind of the same way. When we see those challenging behaviors start to occur, we want to address it early, even though it's a tough conversation, and just say, this is what we can do. This is what we need your help. We're worried that this might be more complicated than just the child being difficult. Can you talk to your primary care doctor and say, we've seen this, this, and this. Is there more to it? Is an evaluation needed? If so, you need to be open and honest with us about how we can support the child. And we'll try and make sure that we all follow the same guidelines at school and at home. But, in the event that the child is hurting multiple people or things like that, we'll have to sit down and reevaluate and see if this is the best setting. But I think trying to have those plans in place and follow those gives the parents some security, but also holds them accountable to say, yeah, we have a role in this too.
Okay, I think there's two more questions. Do you have time?
Yes.
Okay. Um, let's see. So the last question was if it's potentially gearing up for problems if they have children that don't eat while they're in school. And then they expanded on that and said that they only want to eat certain foods, like it's a texture problem, and they see that a lot in schools.
Yes. Okay. I'm an autism mama. There's like 12 foods we eat at our house. Um, and it makes it really challenging, to go places like school and like, what are we going to have there? Um, those of you who serve food, serve meals, not just snacks, have to post that schedule. You have to have that posted so that when licensing comes, they can see this is what you're planning on eating. Having a menu available for the parents in advance is really important. And if you have a child that won't eat food because of certain textures, then I would really invite you to sit down and talk with the parents about, can you provide lunches or can you provide supplements that we could use? When you have a child that has a food allergy and cannot eat something because it endangers their life, then I usually encourage centers to make the switch for that child. Do not give them shrimp or do not give them milk or eggs, whatever it is, peanut butter, those kinds of things. But it can be very challenging to find foods that a child with sensory issues will eat. And that old adage that we grew up hearing, when they're hungry, they'll eat, that is baloney. I know kiddos with autism that will go 3 days without eating and starve to death before they will try something that they do not like the way it feels in their mouth. Um, so really working with the parents, thinking about what on your menu they will eat, what the parent can provide, and making sure that the child eats something. Now, we all know that there are food requirements as far as nutritional requirements in the regulations. But it does allow for doctor's note. And if you have a doctor's note from a child's physician that says, this child has autism, they have a very picky sensory palate, we are trying to get them to eat whatever they will, and we're not worried if they are not served broccoli on a daily basis or, something of that nature. Then that typically meets the need, because the overall goal is we offer it to the kid, but they don't have to have it. But we do have to have things on hand that they will actually eat in order to sustain themselves during the day.